Okay, so the body increases the excretion of toxins and drugs by transforming them into less lipid-soluble and therefore more ionic particles. This is going to be the basis of drug metabolism, which primarily occurs in the liver. Now, there are two types of metabolism that the boards will cover. That's going to be phase 1 and phase 2 metabolism. So let's talk about both. Phase 1 metabolism is going to involve three different reactions that yield slightly polar, water-soluble metabolites. Now, these reactions include reduction, oxidation, and hydrolysis reactions. Now, these metabolites are still going to be active. So when thinking of phase 1, you also need to think cytochrome P450 enzymes. Now, the cytochrome P450 system is going to be a series of enzymes found in the endoplasmic reticulum and the mitochondria of the liver. And these are going to help metabolize the drugs. You've also got phase 2 metabolism, and that's going to include reactions such as acetylation, glucuronidation, and sulfation. Now, phase 2 metabolism typically yields very polar, inactive metabolites that can then be excreted by the kidney. So in thinking of phase 2, you need to think conjugation. Now, what is a simple way to think about conjugation? You can think of it as a means of joining two unique things together. Now, to illustrate the concept of metabolism, I have an example here of how benzene gets turned into phenyl sulfate by phase 1 and phase 2 metabolism. So first, let's start off with benzene. Benzene gets turned into a more water-soluble molecule via phase 1 metabolism, in the P450 system in particular. Now, this produces a metabolite, or phenol in this example, that still may be active and have unique actions on the body. Now, the product of phase 1 reactions is simply a modified version of the parent compound benzene here. Next, a polar group is going to be added via sulfation. Remember, sulfation was one of our phase 2 reactions that can occur. Now, the product after sulfation is simply going to be adding a sulfur group or conjugating a sulfur group to produce a polar, inactive molecule that can then be excreted by the kidney. So in this case, it'll be the phenyl sulfate. So now let's turn all of this into a clinical application. Now I'm going to write down a few options here. People who are slow acetylators have greater side effects than those who don't. So they'll experience greater side effects from drugs like isoniazid, which is going to be a tuberculosis drug because of the decreased rate of metabolism. Because of this decreased rate of metabolism, there tends to be a higher concentration of drug within the body given a same dose and frequency as a normal acetylator. Typically, Caucasians and African Americans tend to be slow acetylators, while Asians tend to be fast acetylators. However, acetylation speed is genetically determined, so this is just a general rule of thumb. Now I got a question for you. I wrote down some options here. Given the options of a 6-year-old, a 30-year-old, and a 70-year-old, which patient would you expect to have the highest risk of side effects while taking isoniazid? Give you a second. Choose one of these three options. Which patient would have the highest risk of experiencing side effects while taking isoniazid? Alright, got an answer? The answer is geriatric patients. Now, geriatric patients lose phase 1 metabolism before phase 2 metabolism. So I would argue that the 70-year-old would experience the greatest risk of side effects. Now, you can remember this by using the memory aid, geriatric patients retain gas. And then gas stands for the acronym of phase 2 conjugation types such as glucuronidation, acetylation, and sulfation. Now, the 70-year-old patient would have a higher risk of having side effects due to the metabolism after taking isoniazid. Elderly patients, especially those with kidney or liver problems, may require reduced doses of some medications. As promised earlier, let's now return to the concepts of efficacy and potency. Let's quickly talk about agonists. An agonist binds at a target receptor and is going to stimulate an effect. So an agonist stimulates an effect. Alright, some agonists tend to stimulate the receptor and cause a full effect. These are termed full agonists. It makes sense. On the other hand, Some drugs stimulate that same receptor, but they don't create as big of a downstream effect as that full agonist would. These drugs are termed partial agonists. So how do agonists play into the picture of efficacy? Efficacy is defined as the maximal effect a drug can produce. So efficacy is defined as the maximal effect a drug can produce, which is irrespective of the concentration required to achieve that effect. If a drug has a very high efficacy, they should produce an almost maximal drug effect. Some examples of high efficacy drug classes include analgesics, antibiotics, antihistamines, and decongestants. Another term we need to consider is potency, where potency is the amount of drug to achieve an effect. So potency means it's the amount of the drug that you actually need to achieve that effect. So potency of a drug is directly related to the drug's affinity for its target receptor. The higher the affinity for the receptor, the higher the potency of the drug. Some examples of high potency classes include chemotherapeutic agents, antihypertensive agents, and antilipidemic agents. Up to this point, we have talked about the different ways the body processes the drug. Now let's focus a little bit on the pharmacodynamic portion of pharmacology. Now recall that pharmacodynamics refers to the effects of the drug on the body. Now the USMLE loves to test your knowledge on the concepts of competitive antagonists, non-competitive antagonists, and also partial agonists. Now by testing, you should be able to instantly recognize all three forms, so don't be surprised if they show you an unlabeled graph here and expect to determine what type of agonist or antagonist is being depicted. So now let's break this concept down. The y-axis is going to be the drug effect, and the x-axis is going to be the dose. Now, drawn in is going to be an agonist here, or a drug that's going to exert some effect. Notice how at a certain dose of this drug, the agonist will exert a maximum effect. So we'll eventually reach that 100%. So now let's add in a competitive antagonist. You can see the effect of a competitive antagonist is to shift the curve to the right. Notice how we're shifting the curve to the right there, which represents a decrease in potency with no change in efficacy, meaning we're still able to achieve that 100% maximum effect, but we'll need to increase the concentration. So the dose is increasing, but the effect is still 100%. Alright, so the effect of a benzodiazepine, such as diazepam on a GABA-A receptor in the presence of flumazenil, is an example of competitive antagonism. Now, in this graph, diazepam is the agonist. Diazepam is the agonist, and flumazenil is the competitive antagonist. So, the shift to the right would represent flumazenil plus diazepam, or an agonist plus an antagonist. So, after saying this, what do you expect is the treatment for a benzodiazepine overdose? So the treatment for a benzodiazepine overdose would be flumazenil. Now, flumazenil decreases the maximal effect of any given dose of diazepam. Therefore, it's useful in the treatment of benzodiazepine overdose. What is a potential serious side effect of benzodiazepine withdrawal? You must be careful and taper the flumazenil so you don't induce seizures. Alright, our next example is going to show a curve of a non-competitive antagonist. Now, here, the curve is shifted down. Notice how we're not having a full effect as the agonist. So an agonist plus a non-competitive antagonist will produce a smaller effect. Alright, increasing the agonist concentration, so if we move over on the x-axis, will not have any effect on the maximum effect. So notice how no matter how much agonist we load here, in the presence of a non-competitive antagonist will not exert a maximal effect. An example of this would be norepinephrine plus phenoxybenzamine acting on alpha receptors. Now, phenoxybenzamine is a non-competitive antagonist at alpha receptors, So no matter how high of a concentration of norepinephrine, which is going to stimulate those alpha receptors, the phenoxybenzamine will prevent the epinephrine or the alpha receptors from being fully utilized. So therefore, this drug is useful in treating hypertension in patients with a pheochromocytoma. Now, we'll cover this more in the endocrine section, but pheochromocytoma is a tumor of the adrenal medulla, specifically the chromaffin cells, which are going to release large amounts of catecholamines, and those will go on to stimulate the alpha receptor. So if we have an alpha receptor here, phenoxybenzamine is going to block that receptor so norepinephrine can't come in and activate it. So therefore, phenoxybenzamine helps antagonize the effects of a catecholamine-releasing tumor. Similar example would be glutamate and ketamine on NMDA receptors. So then we've got one more graph here that I want you to recognize. This third graph depicts a partial agonist introduced to the picture. Now, partial agonists act on the same receptor as a full agonist, but with reduced maximal effect, or decreased efficacy. As you can see here, you're not reaching 100% of the maximal effect. Now, potency is going to be a different variable, and it can either be increased, decreased, or unchanged. Now, this independence of potency and efficacy is an important topic on the boards that will be frequently tested. In this plot, for example, potency is shown to be increased in this particular case, but it can be either. So remember that. A key characteristic of a drug class is that when partial agonists are given alone, they act to stimulate the receptor. However, when they're given in the presence of a full agonist, they act to reduce the overall effect. Now, an example of this would be morphine and buprenorphine at the opioid mu receptor. When buprenorphine is given to an opioid-naive person, he or she will feel an analgesic effect. However, when it's given to a heroin addict who's used to a regular supply of full opioid agonists, he or she may go into withdrawal because the receptor is only being partially stimulated. Even when heroin, a full agonist, is administered, its effects will be partially blocked by the buprenorphine.